All right, welcome everyone, and thank you so much for joining us during Johns Hopkins Alumni Weekend Goes Virtual for this Hop Talk Spotlight Coronavirus Resource Center, defining moments for Johns Hopkins and the world. My name is Rudy DeLeon Dinglas, a senior advisor at the Johns Hopkins Centers for Civic Impact, where I work with various government practitioners across the country and the world to enhance government operations through best practices in data and performance management. Along with the reunion and homecoming office, we are so pleased to bring this session to you today. I will be this afternoon's moderator and will facilitate the Q&A session after the presentation. I encourage you to submit your questions using the Q&A button on your screen, and we will address them once our guest speaker's presentation is completed. Our guest speaker today is someone who I've had the pleasure of working with this past couple of years, a great mentor and a true leader, Ms. Beth Blauer. She is the executive director and co-founder of the Centers for Civic Impact at Johns Hopkins University. Beth is a dedicated public servant and international expert on government performance programs and has spent her career working to improve people's lives by bringing data into government's decision-making processes and service deliveries to improve citizen outcomes. Since the center's opening in 2015, Beth has successfully worked with and coached over 140 mayors from around the globe to advance the use of data and evidence. She has built the organization to be a leader in data-driven insights for city leaders and public sector practitioners across the country and across the globe. Prior to leading the Centers for Civic Impact, Beth has designed and launched Socrates GovStat program or platform for federal, state, and local governments. Having initially entered public service as a juvenile probation officer in Maryland, Beth was quickly promoted within the department, quickly rising to the role of chief of staff. It was in this capacity that she began working on the creation and implementation of state stat. In 2008, then Governor Martin O'Malley asked Beth to lead his nationally recognized state stat program. Beth graduated with a Bachelor of Arts from the University of Maryland, College Park, and she holds a JD from the New York Law School. She's a recipient of the American Society for Public Administration's Center for Accountability and Performance Award for her work as the director of the Maryland State Stat. So, without further ado, Ms. Beth Blauer, the floor is yours.
Thank you, Rudy. Thanks so much for the introduction, and thanks everyone for joining us today. So one of the big pieces that Rudy didn't mention was that as part of our work here at the Centers for Civic Impact at Johns Hopkins University, we are the home to the Coronavirus Resource Center, which has been sort of the preeminent source for COVID tracking data and analysis over the last year. We've had over 1 billion visitors to the site, and we've had almost 10 billion calls to our underlying data. And today, I'm going to talk to you about how we got here. I'm also going to put a little bit of a plug in for another panel that's happening this evening with our colleagues at CSSE, who are going to go into much more detail around the technical aspects of the data. But I'm going to talk to you a little bit about the history, where we are now, kind of how we ended up landing on some of the data visualizations that we share on the site. But really, I would love for this to be a conversation with you all. And so, as Rudy said, I encourage everyone to put questions in the chat. And as we start to see them coming in, we'll start addressing them in turn. But I am going to share my screen and take us through a little bit of a presentation on the development of the map and everything that has gone into getting us to where we are now. So without further ado, I'm going to... All right, Rudy, will you just let me know if you can see my screen? Just want to make sure that
Yes, we can.
You can see the slides. Great. So in January of 2020, there was an emerging virus that was affecting China. As we all know, COVID first started in the region of China. And we had a group in CSSE, in the engineering school, in the Whiting School of Engineering, that had spent a significant amount of time tracking and mapping out communicable disease and the intersection of disease and the built environment. And so they decided to use a platform that they have used for tracking other diseases like measles. And that was a GIS platform, a map, that would allow them to track the spread of this disease, which at the time was limited to this one particular province in China. And that was the very beginning of this global map that has become the preeminent resource for news outlets, for individuals, to actually track this disease that has dramatically changed all of our lives. At the same time, I was working with some colleagues, and we were about to plan a trip abroad. It was February early. We were going to go to India and Israel to do some work with mayors as they thought about some of the work that they were doing. And I was trying to do as much research as possible about the safety of the trip and whether or not it would make sense for us to go on this trip from a research perspective, but also from a safety of staff perspective. And oops, sorry, I'm gonna make sure that you can see. I think I might be in the wrong view, so I'm gonna stop and make sure that everyone can see the right view. Here we go. Is that better, Rudy?
It's coming up.
Yep, can you see it now?
Not yet.
All right, let's see. How about there?
Perfect.
Okay, thank you. Sorry about that. So we were trying to figure out whether or not we were going to go on this trip, and I was trying to find the best information. And it turned out that this map that this entrepreneuring team in our engineering school started was this most important resource. It was the only place where we could really find granular information about where the disease was, where it was traveling. And not only did we realize that we weren't going to be traveling abroad, we started to think about what was so important about this data set and how it might be able to help us as we think about the support that we were providing to mayors and governors already. We realized very quickly that we needed to have a very granular understanding of the impact the disease was going to be having on populations, and we wanted to do it in a way that could immediately inform public policy and some of the decision making that was coming down the pike. And so I approached the team. At CSSE, and I said, I think that we need to create a view of the map that's really focused on the United States and allow for the US view of the map. While the global map was really great at aggregating all of this international data, I really wanted to start to create some context around the intersection of this data and what was already happening here in the United States. And so we were looking at the early returns, and as the first cases started to hit the shores of the west coast of the US, we started to see a very natural data structure emerge in how people were tracking COVID. And that data structure was really down at this county level. And I thought if we could have a very clean view of every single county in the United States and start tracking at that very local level what was happening with the coronavirus and where we were seeing cases, we could start to also shape some of the policy making that was going to be so critical in containing the disease and thinking about the disease from a public health perspective in the absence of therapeutics and vaccination. And so we started to look at what it would look like to create a system of data that could get pulled at these local levels. But we also knew that we were seeing some other, as the weeks were marching on, sort of concerning impacts that were happening as it related to who the disease was affecting, how the disease was functioning in different geographies, and how it was responding to different shocks that were happening across the United States. And so we started to look at data from the perspective of three core facets. The first facet is that we wanted to make sure that when people were accessing COVID data, they also had some basic baseline information just around how healthcare was provided in the US. There is an overwhelming assumption that people access healthcare, that people were accessing healthcare proportionately. And we wanted to make sure that it was clear that there are many places across the US that were going to have to confront COVID that were not necessarily prepared for it. So we started looking for data sources and started aggregating data around bed capacity, ICU capacity, how people accessed and paid for healthcare. And we really wanted to make sure that the healthcare information was also being paired with the COVID data. So if you are on our map and you look at the county-based US version of the map, you can drill into any county and see the data that you see here in this dashboard. We also knew that COVID was disproportionately affecting Black and Brown Americans all across the country, but we weren't really clear on the data because the data wasn't being shared. And I'll talk a little bit later about kind of the hurdles that we had to overcome to try to get some demographic data. But what we did do was we decided to put alongside our COVID tracking just basic demographic information so that you could really see, if you were drilling down to those areas that are being hardest hit by the virus, what those communities look like. How many of the population were in that most risky age category? How many of the people that live in a particular geography are going to be disproportionately affected by the most severe impacts of the disease? And so we started to really pair, again, this basic sort of demographic data so that people could get a sense as they are looking at this data, who the disease was really affecting, especially where it was affecting it. And then we started to take this granular view of the data itself. So we started tracking cases over time. We started doing some late analysis of those cases. And then we wanted to give a kind of a long-term picture and a short-term picture of the data. So these dashboards became a critically important way for people to see how the virus was impacting their communities. To give you a sense of the 1 billion views that we've had of the site, the majority of those people are lay people who are just trying to seek out good, solid information about COVID and about COVID in their community. These are people that are trying to make decisions about, am I going out today? Am I going to be wearing PPE? Am I going to be going to the grocery store, have my groceries delivered? Should I be engaging in high-risk behavior, knowing that there are certain conditions that are present in my community? And these are public policymakers that are looking at specific impacts that the disease is having on communities. And we realized that this resource that we had been creating, this resource that had been proliferating over the several months, was really probably the most significant moment for public data in my lifetime. And I've been working in public data my whole life, trying to get people to care about data in a way that behave. And it became also incredibly important that we were not just sharing this data, but that we were sharing this data and we were pairing it with the world-class subject matter expertise that existed here at Johns Hopkins University. We are lucky enough to be working alongside some of the most accomplished epidemiologists, some of the most accomplished researchers when it comes to vaccinations, some of the most accomplished ICU doctors that have been at the front lines of fighting this disease. And we wanted to make sure that their voices were really impacting the way that we were thinking about the data. And so we started to expand our work beyond just our tracking maps into analysis that was really purpose-built to start to bring together this world-class subject matter expertise with the data and depicting the data in a way that allowed us to align it to areas that we knew were going to become even more important. And so the Coronavirus Resource Center was launched really very much in a way to leverage and to really speak with this voice of not only we are the place where the data lives, but also we have the expertise that we can start pairing with it. And we want to help shape this international narrative about how we respond. And so we started to think about different ways that we could depict this data that would allow actions that could support decision making and that would inform daily lives. And so you can see this is just a sample of some of that analysis, but if you go to the CRC, you'll be able to actually really explore all of these interactive charts and graphs and maps. And with it is paired advice from our public health experts that have really been shaping, identifying gaps, helping us really think about the actions related to the virus itself. And I'm going to talk a little bit about one of the most critical elements of our analysis that we've spoken most about in the public, and that is we know that the virus has disproportionately affected Black and Brown Americans, but one of the biggest challenges in tracking the virus itself was the very fact that the data wasn't being shared. So the states who are publicly sharing the data and all the data that's in the Coronavirus Resource Center and in our maps and charts is actually being pulled from these public data systems that exist in states. And when we started to pull that data, we realized we were getting aggregates of that data, but we really needed it to be broken down. We needed to know what populations were being most disproportionately affected. We knew anecdotally that some of our neighbors are being disproportionately impacted, but it wasn't validated in the information. So we developed this map, which has been at the center of this analysis. And when we first started, the majority of these states were grayed out. We had very limited visibility. But for confirmed cases and deaths, we nearly have 100% coverage of the US, where we can really dig into that data and see who and how this disease is impacting communities. But I'm going to call your attention to testing, which is still incredibly difficult to get granular data on who has access to testing. And I really want to talk about this one because it's so critically important. We know that there are huge populations across the United States that still have to travel 1 to 2 hours in order to get COVID tests, that they don't have reliable public health assets within their communities that would allow them to even know whether or not they have COVID or whether or not they need to seek additional medical care, whether they need to engage in a quarantine. And this has been a real impediment to communities being able to functionally respond to the public health crisis of COVID. With limited testing and without access to testing, we know that there are communities where spread is happening at a community level in much more accelerated fashions. And when it does hit those communities, not having the information or the ability to test becomes incredibly problematic. We're also seeing testing declines. As we've seen the ramping up of vaccination, we see a very concerning trend in the data that's letting us know that testing is starting to decline, which means we're not doing the kinds of surveillance that would allow us to really effectively use all of the levers that we have to respond to the disease. And so this is an area that we know that we focus a significant amount of our analysis and time on, because it's been at the center of our ability to think about the disease and to confirm where the disease is in our communities. This is one of my favorite graphics, and it is my favorite graphic mostly because this, for me as a public policy nerd, is really where the rubber meets the road. Before the availability of vaccination, public policy was our single most effective tool in the fight against COVID-19. And what you see here, all of these green and red lines are different policy actions that governments have taken in order to control the disease. So if you look at a place like New York, you can see that there was a very purposeful, granular approach to the public policy, where when they had this initial spike, they were very aggressive about closing their economy, closing their schools, limiting interactions in public, limiting private interactions. And And then you can see a slow reopening. You can see in the data that the disease was held at bay, but then you start to see this second wave that's coming, and you can see again this kind of clamping down where the public policy, those closing decisions reactivated to try to control that disease, and then you start to see the data coming back down again, and then you see these series of opening actions. This is not an experience that was the same in every state because there was a lack of standardization and a lack of sort of clarity around how we should think about policy. It was disproportionately mandated in different places. And so we saw some states really struggle with this notion, or we saw really widespread opening decisions without that kind of retraction when the data would tell us that retraction was appropriate. And this is a piece that I think is going to be at the center of a lot of the research when we look back at COVID. We'll look back at those policy actions, and we'll look back at the sort of lack of standardization both around the data and around the public policy decision making that will have a pretty big effect on the way that we plan for the next pandemic. Another area where I think we have sort of underutilized the ability to use data to really understand our impact and our ability to intervene is in contact tracing. We do a significant amount of work at the CRC on thinking about how states have used this tool. And we know that contact tracing with an aggressive surveillance testing approach is probably the most significant way in the absence of immunity to really control COVID. And so we looked at how states were doing contact tracing and tried to really create a practice around contact tracing. So we had, as many of you may know, a contact tracing course that was launched at the School of Public Health where we had hundreds of thousands of contact tracers or aspiring contact tracers take the course. But we also started to think about what data is being collected and how that data should be, how we should be thinking about contact tracing as sort of a center of a new reemergence of public health, even post-pandemic. And then for those of you that are here in the United States, I encourage you to take a look at especially our regional views. We have regional views of every state in the US, and our most recent addition to the regional views and to our analysis in general is that we are now closely tracking, and we've generated our own independent collection of vaccination data. Vaccination data, one of the things I will highlight, again, the CDC as of today is still reporting just about only information on half of those fully vaccinated, the demographics of those individuals. Why is that problematic? In the last mile of vaccination, we're really going to need to know which communities are not protected, so that we can target communication, so we can think strategically about outreach. And the inability to have sort of standardized reporting around this demographics is probably going to be one of the most significant challenges that we're going to have to overcome in the next several months. But in the meantime, we're doing the best that we can at the CRC to collect all of this data and to think about vaccination and the alignment that we can provide between tracking and figuring out where there's opportunities to improve distribution. We have taken this data and we've used it in many, many different ways. You know, we talk about the impact that we've had internationally by being the sort of system of reference, but we also were able to take the expertise and the fact that we were entrenched in this data collection and use it as a platform to develop resources for public policy makers. So we at the beginning of last summer created a series of metrics that we encouraged mayors to collect as they were thinking about their own reopening schemes and how they were going to think about the responses that they were taking in an ongoing fashion. And we worked with mayors all across the country as part of a joint initiative with Bloomberg Philanthropies as we really thought about how can we support mayors and help them think about creating a common language amongst themselves. And so we had a cohort of mayors that started collecting the same information. And what we saw was the ability to actually take this information, this data that started in this mass collection effort, that was then shaped into these measures and now aligned to outcomes that we're seeing in places like New Orleans and places like in places like Baltimore, where we've been able to be very granular in the way that we think about the intersection of those policy decisions and the data that is being collected around the disease. And it has had a significant impact on the way that we not only think about how we're dealing with our current crisis, but also how we start preparing for those crises and for just a real hard look at the public health system itself. One of the biggest realizations here, and one of the biggest observations that many of us in the field of public policy have made, is that COVID has exposed some of the historical ills that have been part of the public health canon for generations. And we are now forced into the position to have to really think about them and address them. And so this data is one element of a backdrop of what we hope is a catalyst for real change in the field. And so I'm going to stop there. This is a very bit overview, and I'm going to hand it back to Rudy, who I think has some questions coming in from the chat and may also have some other questions. So Rudy, I'm going to go ahead and stop sharing my screen and then hopefully open it up to some discussion.
Definitely. Thank you for that, Beth. Very, very telling numbers, very robust. Really appreciate that. And it's a resource that's widely accessed worldwide, as you mentioned, and as we've seen. Can you tell the audience a little bit more about the quality control process that goes into ensuring that these numbers are reliable?
So the CRC is not just, we are the home of the CRC, but the CRC is absolutely a joint initiative between what's happening in the Whiting School of Engineering, what's happening also, we are relying pretty significantly on a partnership that we have with the Applied Physics Lab as well. And so behind the scenes, there is quite a significant and sophisticated data architecture that does several things to help protect the quality of the data. So what we've done is we've created a manual process to start. So anytime that we're going to bring in a new data feed, we manually collect that data. So I'll use vaccination as an example. The vaccination data the vaccination data came in, and we started looking at it, and we started to pull it literally just the way that you probably did in school, where you would do sort of manual bringing in data and plotting it into a spreadsheet, and we tracked it day after day, and we will start to make observations about that data. We'll start to see how regularly it's updated. We'll start to gather metadata on that data and start to do a probe of that data, and then we build a script. So we build a script that allows us to automate the pull of that data. And then it comes into our environment that the CRC is built on, and we've created anomaly detection at the input. So we use another script that sits at the front of our data infrastructure, and any new data that comes in goes through anomaly detection. So it will compare data from one day to the previous day. It'll compare data from one day to the past 7-day averages. It will look for outliers. It will look for sharp increases, sharp declines. And then once it goes through that detection, if there's no detection of any anomaly, it'll get passed through to an analysis or a processing part of the infrastructure, where it will essentially get shaped into the condition that it will be when it gets publicly released. And before it gets publicly released, it goes through yet another view of anomaly detection. So if we plotted that particular data point into a chart, and all of a sudden it is off the charts, or all of the neighboring areas look very different than the area that we're reporting, it will send us a signal saying, hey, take a look at this before you publish. There's something that looks very off about this data. And then we go back and we'll do a little bit of investigation, and sometimes it's because there is a spike or there has been an event in a particular area. Sometimes a government dumps a lot of data on a Monday because they didn't report Saturday and Sunday. Sometimes there'll be a government that has gone back and realized, oh, we forgot these 3,000 deaths and we got to pour them into the data source. And what we've tried to do is that as part of our data collection, anytime we see any kind of this erratic reporting behavior, it's deeply documented. So we will put it into the data resources, and then we will update all of the underlying infrastructure with readmes and descriptions and real definitions around why those changes in the data have been present.
Wow, I know the center was busy, but not that busy. Wow. Thank you for sharing that with us, because a couple of the Q&A attendees have asked that same question. My next question to you is, what has been the biggest challenge for collecting this data and sharing it to the public?
So, the biggest challenge has been the lack of standardization. I don't think any of us on this team ever thought that we would be in April, almost May of 2021, without there being a global standard around how we're defining cases, deaths, tests, vaccinations. I certainly didn't think there wouldn't be a standard here domestically. And because of that lack of standardization, we have states that really had to scramble for defining things on their own. And so, very early on, we saw a lot of missteps where we had one state that would include antigen testing with PCR testing, with antibody testing, just to make their testing numbers look inflated. We had other people who were undercounting. We had situations where, like in New York City, they count probable cases, but the state of New York doesn't count probable cases. And so there's a disconnect between what was being reported at the local level versus what was being reported at the state level. These challenges are still persisting. In the absence of these standards, it's very difficult to do apples to apples comparisons. And we really, in a place like the US where we have fluid borders, we need to be able to do apples to apples comparison. We need to be able to be smart about how we're managing. And the lack of standardization has absolutely been the Achilles heel of this work.
Thank you. Thank you for that, Beth. Next question that we have for you. How has the data collected and presented evolved as we go through the pandemic? Right now, we're all about vaccination. How has that affected the data?
So, we have a regular routine governance process that we've instituted at the CRC, and it started very early on. So it started with daily calls. This is what the data landscape is looking like. This is what's coming in, and we meet every single day to kind of track what's happening, and that's really allowed us to also be really strategic about looking at the frontier of what data we can expect to also be coming our way. And so, like for vaccinations, we already had a plan in place. We knew that vaccinations were coming. We also were tracking the evolution of which ones were going through approval processes through the emergency use authorization. So we knew that there were 3 potential vaccines, and that 2 of them were 2-dose vaccines, and 1 of them was a 1-dose vaccine. And we were going to need to essentially create data containers for both of them and still be able to aggregate them into fully vaccinated people, because that was going to be the measure that a lot of people wanted to key into. And so we were able to have these conversations in anticipation of this data coming into the platform that allowed us to essentially design the site. And then as soon as that data started to really hit the market or come into the state resources and the state dashboards, we were able to start collecting it almost immediately and then sharing it in these aggregated formats. The thing that does evolve every single day is also the analysis. So we also are thinking about what is the data telling us and what kind of advocacy should we be doing from a public health perspective, from a public policy perspective. And so the analysis that we do is often informed by conversations that we're having with experts across the university who have really been helping us think about the strategy and how we can depict this data in ways that can be incredibly valuable.
Okay, thank you for that. And related to another question by Anita on the Q&A, and to one of my questions that I had for you, what do you think will happen in the future with this data? What are the plans, post-COVID for that?
So this has become a question that is really shaping a lot of the work that we're thinking about now, which is this is going to be one of the most important research tools that we're going to have when we think about not only emergency management planning, community planning, but obviously the public health aspects of it. And so the COVID data will remain intact as an asset here at the university, and it will be open. We made a commitment very early on that all of this data would be open, and we use what's called a Creative Commons license. So anyone can use the data. We just ask for attribution back into the university, but it is open to anyone. So we've seen the data. So I think I talked earlier on that we have, you know, a billion page views. We have a billion people that have come, or a billion views of the pages within the CRC, but we have, you know, upwards of 10 billion calls on that data, which means we know that researchers we are already tapping in to the data that's been collected, and that is fueling research around a whole host of different outcomes about transportation infrastructure, communication infrastructure. We're embedded in business systems. We're embedding this data in many places, and so it is going to live in some form or fashion here at the university into perpetuity. So it can serve these research purposes. But we've built this incredible infrastructure, and so I know that we all at the CRC have a big aspiration for figuring out. Okay, we have positioned ourselves now as being able to do this. We know that there is a demand. There are lots of things that communities are impacted by, whether that's poverty, whether that's violence, whether that's hunger, that we think probably could use the same kind of rigor and data tracking. And so we're thinking actively about what that looks like as we kind of define the path for our future.
Thank you. And you touched on lightly earlier about a billion views. How do do you monitor, does the CRC monitor for any misinterpretation or misrepresentation of the data? Because it's widely shared in the media. We see it often in major news networks. Does the center watch for that? What happens? Do you all correct them if that's needed?
There were, you know, especially early on, there were lots of what I call armchair epidemiologists who, you know, we had someone very early on use our data and tried to make a case for the fact that we had achieved herd immunity through community exposure, I think like a year ago, April. And, you know, the thing that we sort of insisted on in the kind of governance that we put into place in the CRC was that we were going to just continue to kind of try to get out with the data as much sound public policy and public health advice as possible, to try to combat every misinformed armchair epidemiologist would have been tough. We know the ones that got the most traction. We tried to create counterpoints quite publicly. Our experts, you know, Dr. Nuzzo has been a fixture on the cable news networks and on NPR. I've had also the opportunity to do a lot of that kind of speaking around not just, you know, what we were observing and experiencing. We both co-authored a New York Times op-ed that was really the focus of like, hey, this lack of standards is dangerous. It's really going to continue to hamstring our efforts, and we continue to do that kind of outreach. It's been for us very important because of this opportunity that we've had to kind of lead this work, that to really lift those voices. One other fact that I want to mention about the CRC: it is a team that is composed of data scientists, doctors, epidemiologists, experts, and we are all women-led. Dr. Gardner, who launched the original map, my data scientist colleagues, everyone top to bottom, the teams are led by women. And I think it is a moment for us to celebrate women in STEM in a way that I think, I don't think that part of our story has really gotten out there in such a big way, but I do think it's important.
Wow, I had goosebumps listening to that. I didn't know that, Beth, and I've worked, closely alongside. I had no idea. Thank you for sharing that. I have a question from David here. What proportion of your data sources are publicly available? And have you had to create data sharing agreements for other data sources?
So all of the data that is out in the public, we made a commitment would be derived from public sources. That way, everyone could track back essentially where our data was coming from. There are a couple of proprietary data sets that are part of the dashboard that I showed that had the sort of breakdowns of like the health system data and the demographic data. And so we did early on create some data sharing agreements with those data providers. But what we did is in the negotiation of that, we said we want it to be open to everyone. We don't want it just to be open for us to be able to use a view of it. We want people to be able to take this data from our site and use it in their own analysis. And so through a very similar process like the emergency use that you see in some of the regulatory agencies, a lot of these organizations were like, yes, we agree, like this is an emergency. So Definitive Healthcare, who provided the data through our data sharing agreement with Esri, allowed us to use that data in a way that that we were able to publish it, and we continue to publish it. But ordinarily, those are proprietary data sets, and so our first choice is always public data, and a lot of that is because we want to encourage more and more data to be made public for public use. But in the event, we did have to have some conversations about data sharing, and we advocated very strongly that the data should be open. The other thing is that a lot of people wanted to partner with us in this process, whether they wanted to help us from a tech perspective. But I think that once they realized what the level of use was and how much traffic we were getting, a lot of systems can't kind of really sustain or manage that level of traffic. And so it became a little bit of a natural selection process and what we could deploy on the platform itself.
Thank you. Thank you for answering that. And thank you for David for posting that. I just want to remind the attendees to please post questions in the Q&A. We have about 14 more minutes left, so we'll try to get to as many of them as possible. But I want to go back earlier. You had a slide talking about management metrics and working with cities. How have you seen cities and jurisdictions approach service deliveries, knowing what they know now or what they've seen from the CRC's website?
Yeah, we've had a couple of really great examples. I will highlight the work that we did with the mayor of New Orleans in Louisiana, where the mayor came to us very early on and was like, I know that I have communities that are underrepresented, both in access to the health system and information in my outreach, but I want to be able to sort of predict where the disease is also going to manifest. And so we started using CRC data and lots of city-based data as a way to help the city map out where they would deploy mobile testing resources, mobile outreach resources, so they could stay ahead of the spread of the disease. And so if you look at New Orleans's curve, their curve, you can see that they had a sharp increase in cases, but it quickly came down. But one of the things that I think is so remarkable is that their fatality rate actually stayed quite low. And a lot of that was credited to the fact that they really were strategic about where they placed their testing resources and where they really emphasized outreach in the community to get people to stay isolated if they tested positive, to provide the right kinds of support so that if people needed food or they needed a hotel room to separate from dense familial living conditions, that they were able to rapidly deploy those resources because they knew exactly what was happening. And that was because the mayor insisted that the data be the lead in how they were going to think about distributing resources, how they were going to think about advocating for their citizens. And I think it made a huge difference in their ability to respond to the disease.
Perfect. I think I'm sure Mayor Cantrell and her team appreciates that over in New Orleans. So this is Alumni Weekend, so I want to focus a little bit on Baltimore for one question here. JHU is deeply embedded here in Baltimore City. With such familiarity in Baltimore City, are there any unique challenges or advantages when sharing information compared to when sharing information perhaps with other cities like New Orleans?
Yeah, so look, I think, we also went through a mayoral transition during COVID, which I think is also a little bit of an exceptional experience. And so during that transition, we saw, I think, pretty decent continuity of care and advocacy. So now we have a mayor here in Baltimore who's looking at this data. And one of the biggest challenges, honestly, here is that we have a state mass vaccination site that's being hosted at M&T Stadium. The mayor has no idea who's being vaccinated there. There is a real disconnect between who's being vaccinated and the information that's being collected on those people being vaccinated at the mass vaccination sites versus those that are getting access through city sponsored vaccination sites. And so not having that full picture and knowing who has access, and also not knowing who's not trying to get access to vaccines is going to be, like I said, that kind of last mile challenge. And it is really pronounced here in the city of Baltimore. And that disproportionality is evident. And so we saw a very significant spike in white residents of Baltimore City getting vaccinated in a much higher rate than what they represent in the base population here. And it is incredibly concerning. It's something the mayor is looking at very closely. And he's been doing a lot of advocacy, both publicly and behind the scenes, trying to make sure that particularly Black Baltimore gets access to vaccines and information about vaccines to sort of combat some of that hesitancy that may be experienced in the community as well.
Good, glad to hear that. Thank you so much for sharing that. Going back to some of the data, since I also work with some cities about data, are there data that you think that should be collected that are not feasible?
Well, the demographic data, first of all, if I haven't beaten that one down yet, then I gotta emphasize it. But I also think that there's some health infrastructure data where primary care, the location of primary care, has been another really big impediment. And another piece of really important information that I think has hamstrung our ability to respond, particularly in this crisis, is broadband access. We saw really immediately a lot of health systems transition into remote frontline care or remote visits. If your doctor converted to 100% remote practice early on in a pandemic, and you started to get those sort of early onset symptoms, and you didn't have access to internet or a stable internet connection, you were basically cut off from your provider. And so one of the big pieces of, I think, public health insight that we've learned is that broadband is a public health crisis. And if you don't have access to the internet, whether you're a student who gets cut off from learning or you're a patient who gets cut off from care, it is probably one of the biggest pieces of infrastructure that is going to be able to really define whether or not you get access to what are, I would consider to be pretty basic human rights.
Thank you so much. I know we have a lot of questions for you. We have a few minutes left, and we have a couple of questions in the Q&A that kind of are very similar. So you have this amazing platform, worldwide access to it. What's next, Beth? JHU is now globally recognized as a leader in getting trusted data to the world. Do we stop at COVID?
Well, I hope not. I think if I could see the same level of intensity and tracking, violent crime or tracking hunger, I think I mentioned earlier, I would jump at the opportunity to do it. And we are working on trying to figure out how we can take all this infrastructure and momentum that we've built and think about how we can apply it to some other significant challenges that our communities are facing. But regardless of that, Rudy, you and I get to work on issues like this every day. And so, through Civic Impact, we have the ability and reach. We're in over 250 different cities. We have really significantly changed the baseline for how data is being used in the shaping of public policy. And I am excited to do that for as long as they'll have me here at Johns Hopkins University, as we think about not only generating the sort of the next set of leaders for the public sector, but also investing in the skills of those people that have already been called into public sector work as a way for them to really think about how they can use data in their daily work to improve the lives of people that are living in cities.
Thank you. That wraps up our questions. In the interest of time, I know people have other events after this in the virtual alumni weekend. Is there any other last words that you'd like to share with the group here today before we wrap up?
I just want to say a general thank you. I think one of the things that I found so overwhelming about this experience was that the JHU Alumni Network were the first people to stand up and say, how can we help? We had so many alumni that very early on were sending us notes, encouraging the work, really like observers of the work. So, just a big thank you to the alumni community for continuing to really support us and think about us. And we hope that, as we've kind of catapulted the university into this spotlight, that we've made you proud. But we also really did feel all the support that was being extended to us, and just a real heartfelt thank you to the alumni for continuing to be that sort of cheerleading squad for us on the sidelines.
Well, I'm sure I speak for everyone, Beth, when I say thank you, thank you, thank you so much for giving us your time today, for sharing your expertise and your knowledge. It's been such a great pleasure. We wish everyone safety and health, and we appreciate you joining us for this event today. We hope you enjoyed it. Thank you, and have a fantastic weekend.
Yeah, and thanks, Rudy. Thanks for hosting.